Assalamu alaikum warahmatullahi wabarakatuh. Good day, everyone. I am LAMYAA ALANEZI, clinical instructor of pediatric intensive care pathway in MCH Tobacco Hospital. Thank you for joining this education session. So, on this education presentation, we will cover IV cannulation in nursing practice, which is aimed to review the principle of safe peripheral intravenous access, including indication, insertion technique, maintenance, removal, and complications prevention. So let's begin with the definition of IV cannulation. An IV is a peripheral vascular access device inserted into a vein to deliver the fluids, medication, blood products, and other intravenous therapies safely and effectively. So in this slide, we will review the anatomy of the upper extremity veins commonly used for IV cannulation, and understanding the vein anatomy is essential for selecting the most appropriate site and improving the insertion success. So here we have the cephalic vein are considered the cephalic vein and the basilic vein are considered the preferred vein for a peripheral IV access. Why? Because usually it's a larger, more stable and easier to cannulate. Regarding the median cubital vein, which is located in the antecubital fossa here, okay, is another accessible options, and it's commonly used when you need like a rapid venous access is required. We have also here the dorsal vein of the hands. Can also be used as an alternative site, especially when the forearm vein is unavailable or you cannot access to. Okay, we can use the dorsal vein of the hands. When selecting the vein, nurses should choose a vein that should be straight, soft, or we can say spongy to touch and resideness, as this characteristic increase the likelihood of successful cannulations and reduce the complication. I add here also some principles for vein selections. Careful vein selection reduces the insertion failure and complications. Always assess both arms and prioritize the patient comfort and accessibility when choosing the optimal sites. There is sites to be chosen, and of course, there is site to be avoided, and there is contraindication. So, we will avoid the extremity with a prior mastectomy or lymph node dissection. Also, the scar, tattoos area, or edematous skin area, and the hands or the sites with the fistula. Also, the area with a cast or assistive device. Especially in pediatric, you should to avoid the palmar wrist. Why? Because it can cause nerve injury risk, and the area below the recent vein punctures. Okay, so you cannot reinsert for areas it's already the vein is punctured already. So careful site selections prevent a serious complication. Always assess the full extremity before insertion and document contraindication finding. Okay. We have techniques to improve the vein visualization. So the effective vein visualization, it will enhance the first attempt successful and reduce the patient discomfort. You can apply any of this evidence-based technique before every IV insertion. So first, as usual, you are using a tourniquet. The most important when using the single tourniquet is to confirm the arterial flow remain intact. Second, you can use a warmer compressor or a warmer blanket as we use in pediatric. You can keep from 3 to 5 minutes to dilate the vein. Do not keep more so the baby will not be hyperthermic or get burned. The third, you can position the extremity dependent and below the heart level. Why? To enhance the venous feeling. And the fourth point is to use illumination device if you have in your unit or ultrasound guidance if you're trained for. So if you cannot, you can consult the vascular access team for difficult cases. Peripheral calf gauge selection. Of course, always you select the smallest gauge that meets your therapy need. Keep in your mind the large calf, the lower gauge number, allow a higher flow rate, but it increases the vein trauma risk. Match the gauge to the clinical indications for optimal patient outcomes. So as usual, we have 7 gauges or 7 sides. We will start with the smallest, with the 24 gauge, the yellow one. We can use for, usually are using for infant, not neonate, and the fragile veins. 22 for pediatric, 20 we can use for routine adult use, 18 for the blood product and rapid infusion, 16 trauma and large volume resuscitation, 14 the massive transfusion and during emergency. There is also one size we are using in PICU and in ICU, which is 26. This is for a neonate size. Now we will proceed with the insertion process. So what you will do if you want to insert an IV access. First you have to gather your equipment. What we're gonna need, gauze pad. First you have to gather your trolley, of course, your procedure tray. Second will be the gauze pad, IV cannula, tourniquet, chlorhydroxine, or you can use alcohol swab, IV citro tubing if you want to prepare your IV fluid or IV meds, sterile transparent dressing, your flush, and sure your gloves. And for the sharpest possible, and your infusions for IV pump or syringe pump. Of course, you have to know your spill kit location in case of bleeding. So I added this video, practical video, and then we will explain regarding insertion.
Is apply the tourniquet. We're going to go up, round and down, keeping it nice and tight as we do so. This means that we can easily release the tourniquet without causing any issues to the patient. So if I put that back on again, then we start to have a look to see what we can find. We can see the veins, yes, but what we need to do is find veins that are easily palpable. You can get the patient to flex their hand, and that can bring some of these veins to the fore. We could get the bifurcation here in the wrist. Some patients prefer that because it leaves the hand free. We can tap on the wrist a couple of times, and that can bring the vein to the fore. We're then going to put the antiseptic wipe on the hand and moving round from the centre out. As the antiseptic is drying, we're going to prepare the cannula, folding the wings down. Then we want to pull the skin on the wrist as we dorsiflex the wrist. This tethering of the wrist will help going in at 5 degrees and then adjusting as we go up. We can see a little bit of flashback there, and we can begin to pull the needle backwards. As we do, advancing the cannula into the arm. As we pull the needle off, we're going to occlude the cannula to mean that we don't get any leakage, and we're going to apply the cap to the back of the cannula. Once this is in, we want to release the tourniquet, and then we're going to prepare our flush. So advance the cannula fully, put the flush to the cannula and flush. So we know that we've got an easy flush, so there's no problems. At this point, we now want to tether down the cannula, putting the first strips over the wings, holding it in place. That keeps things nice and secure. Then we're getting the main tegaderm, applying over the insertion site, so that way things have been covered and it reduces the risk of any infections to that wound site. We're coming round again to touch across the front of the port. We're going to remove the outer part of the tegaderm, saving the outer part which contains the date, and we'll remove the overall part of the film. Then we're going to close the port and we're going to apply the dates to the cannula. Some people do apply them higher up, but it's much better to apply them low down under the port so that we can see the cannula site at all points in case we get evidence of infection, such as erythema.
Okay, so we will start with our assessment. First, of course, infection control. You have to perform your hand hygiene before patient contact. Then you have to verify the correct patient. We are using two identifiers, full name and the medical number. Third, you have to make sure the accuracy and the completeness of your physician order, like your order for the type and the amount of IV fluid or medications, additive, fusion rate, and the length of therapy. Number four, you have to assess any allergic history to the medication or either even alcohol or the chlorhydroxine or the latex or even the tape. It can cause allergic to some patients. So now we will proceed to the preparations. You will provide educations to your patient. You will obtain informed verbal consent prior to inserting an IV. Usually it will take only as a verbal consent, yani no need for written consent. Organize all your supply, as we said, on the clinical procedure tray or if you have IV trolley in your department. Then you will provide privacy and adequate lighting. Assist the patient to a comfort sitting or supine positions at the level to easy access. Then you will prepare prescribed IV solutions or medication. You will check, of course, for the solution of the color, clarity, and the expiry date. Check the bag or the bottle for any leak or turn. Then you're going to prepare your infusion tubing. You will open the infusion set to maintain sterility for both tubing in. Of course, you will place the roller clamp below the drip chamber and move the roller clamp to off position. Insert the infusion set into the IV solution bag or the bottle and brain the system. Identify the blood or body fluid spillage. Okay, then you will discontinue the infusion medication solution upon physician order or in the event of severe reaction, anaphylactic reaction, speed shock, circulations overload. You will apply 3 labels to each area of IV site, infusion line, IV fluid, including the date and time of insertion, and the nurse initial and the employee number, avoiding the writing directly on an IV bag or bottle or using a marker pen to label it. Write only on the label. Okay? Then monitoring and care or the maintenance. You have to identify the content and the location of the spill kit in your department. This is the most important. And then you're gonna to proceed with the assessment for monitoring and maintenance. Assess the catheter skin junction site surrounding the area for any redness, tenderness, swelling, and draining by visual inspection, palpations through the intact dressing and through the patient's reports. About any discomfort like pain, paresthesia, or numbness and tingling. Observe the patients and the site minimally at least for every 4 hours. Okay? Every 1 to 2 hours for patients who are critically ill, sedated, or conjunctive defects, or pediatric. Hourly for a neonate pediatric patient, more often for patients receiving infusions of Viscount's medication also. Notify the physicians about any sign and symptoms of possible catheter-related infection. Site changing for an adult